Christine Schneider, the Visceral Voice.
Welcome to the Visceral Voice podcast. I'm your host, Christine Schneider. Every 2 weeks on this podcast, I talk with voice specialists, manual therapists, health specialists, psychotherapists, movement practitioners, and professional voice users about voice science, function, medication, movement, puberty and aging, and everything in between. I am on a quest, not only to become a better manual therapist, but also to learn everything I can about the living, breathing body and its intricate connection to the voice. This podcast documents the continuation of my learning and my experience as a professional singer, a nutritional consultant, and a manual therapist. Join me every 2 weeks as we strive to provide current, knowledgeable, creative, and compassionate information to help restore, regain, and create happiness and success in your vocal journey. Hello, everyone. If you haven't already filled out the questionnaire, please do so. This really gives me ideas of what direction to take the podcast in, and I really appreciate your ideas. So thank you for filling out the questionnaire for those who have, and thank you for those who are going to. If you enjoy this podcast and you would like to become a supporter for a donation of $5 a month, you not only get my complete gratitude, but you also get to send in your questions for my guests. You can find a link for Patreon in my show notes. Thank you so much for considering becoming a supporter of the Visceral Voice podcast. I am very grateful for your consideration. I hope that you continue to enjoy the episodes. Please give me your feedback, and I look forward to hearing from you. Shirley Gherson is a speech-language pathologist who specializes in the rehabilitation of people who have vocal fold injuries and airway disorders, such as paradoxical vocal fold movement, vocal cord dysfunction, and laryngospasms. With almost 20 years of experience, she continues to find her work both fascinating and incredibly rewarding. At NYU Langone's Voice Center, she provides diagnostic and therapeutic care. She collaborates with laryngologists to determine the cause of people's voice problems and designs treatment plans tailored to each person's diagnosis and vocal needs. She is also a voice therapist and provides people with education, exercises, and strategies to restore normal voice use. When necessary, her patients might combine this with medical or surgical care. The majority of her patients use their voice for professional and occupational use, including teachers, fitness instructors, singers, actors, salespeople, and courtroom attorneys, among others. She understands that her patients' voices are essential to their livelihoods, and she works to help them return to full vocal health as soon as possible. In addition to her clinical work, she teaches graduate students and provides advanced training to student clinicians who want to specialize in the voice. I am thrilled to bring you my conversation with Shirley Gherson. Hi, Shirley. Welcome to the podcast.
Hi, Christine. I'm so happy to be here.
I am so happy to have you here. I think among all of my colleagues who are really, really wonderful, I have always felt like you're a soul sister. So I am so thrilled.
I feel the same way.
So I'm so excited to have this discussion with you. I'm glad that you're here on the podcast today to talk about breath.
Great.
So you are a speech-language pathologist. Can you talk to us about your journey into becoming a speech-language pathologist?
Sure. So, like a lot of my colleagues and friends who specialize in voice disorders who are in my field, I started a journey with a full intention of becoming a professional singer. So, I enrolled in the vocal performance program at Boston University. And it was around the second year that a close friend of mine who was also in that vocal performance program started to get hoarse. And she was getting hoarse frequently enough where she was really worried that something was wrong. So she was Greek and she didn't have any family in the area. So she asked me to accompany her to see a doctor. And we ended up going to see a voice specialist at the Massachusetts Eye and Ear Infirmary. And, unbeknownst to me at the time, it was one of the premier voice centers in the country. So, like, just by sheer luck, I had my first encounter with a voice evaluation at that center. So, I remember I was in the exam room with her when the doctor started the endoscopy, the rigid endoscopy, and I got to see the vocal folds for the first time. And it was so bizarre. It was shocking, right? I mean, it just looks like an alien inside the throat. It's totally weird. And it was absolutely wonderful. I mean, I was hooked. And so she was prescribed a course of voice therapy, and I attended some sessions with her. And in my observation, it just struck me. I said, "This is exactly what my career is going to be." And it's just such this perfect blend between biology, which I've always really been fascinated with, the just life sciences, and vocal expression and counseling. So I promptly switched my major and I never looked back. And the funny thing is what's more unbelievable is that I am just as fascinated and excited about this field as I was 25 years ago when I started the journey.
Mm, so
Yeah.
true. I am too.
Yeah.
That's the amazing thing about the human body. There's always awesome information coming out, and there's always more to learn.
There's so many layers. So many
Yeah.
layers, right. And the smarter I get, the more I realize how little I really know about the intricacies of voice and breath and
Mm,
emotion, which all tie
yeah.
together. Yeah.
What a great journey.
Mhm.
So, leading into our discussion about breath, can you talk a little about the forces that influence breathing, particularly gravity and the elasticity of the lungs and the rigidity of the skeleton?
Sure. So, just a brief tour around the basics of the anatomy and physiology of respiration. We've got these lobes of lungs, which are just spongy tissue. It's about 70% air, and it's housed in our chest cavity with the spine that's in the back and the ribs curving around the sides and the sternum in the front. And the ribs are glued together by this muscle that we call the intercostals. There's extrinsic and intrinsic. And then those intercostal muscles control the lifting and the lowering of the rib cage. And then we've got that famous diaphragm that we all know from our singing lessons. And that's a dome shaped muscle that sits at the floor of our chest cavity. And the skeleton is like scaffolding for our muscles and for the organs that are inside. And so, one of the reasons why trainers, voice trainers, and speech pathologists involve training postural strength and range of motion is because it's so important for healthy respiratory function. And if there's any rigidity or restriction of movement in those skeletal joints, it can affect your breath, and then of course the muscles involved in making sound. So when we're breathing quietly, when we're at rest, what we do is we inhale by expanding our chest cavity. That's done by contracting these external intercostal muscles, which are between the ribs in the rib cage. And at the same time, we're contracting the diaphragm. So the diaphragm moves down and out. And that expansion of the chest lowers air pressure, and we breathe in. And then when we exhale, we just relax our intercostal muscles and our diaphragm, and that kind of domes back up to its original shape. And that contracts the space in the chest cavity, which increases air pressure, and then we exhale. Now, that's just a very basic version of what actually happens. There's a lot more by way of neurology and the exchange of gases with the afferent sensory nervous system that's involved in that. But from the standpoint of just the nuts and bolts, that's what happens when we're at rest. Now, with exhalation, it's also assisted by gravity, and then what's called elastic recoil of our lung tissue. So, elastic recoil is this rebound effect of the lung tissue. It's a character of the lung tissue once it's been stretched by inhalation. So, I like to, when I teach this in my voice disorders class at NYU, I talk about it like it's a stretched out spring, right, that
Mhm.
wants to go back to its original state. And then We also have elastic recoils that are present in the movement of our thorax, which we can think of like a compressed spring. The way this plays out is that at the top of our breath, we have the elastic recoil of the lungs that's very high, so it's assisting our exhalation. And then when we're at the very bottom of our breath, we have that elastic recoil of the thorax, which can assist in our inhalation. And then, of course, there's a point at which the elastic recoil of the lungs and the thorax are at equilibrium, and we call that resting expiratory levels. So that's essentially where the respiratory system is at rest, right after a comfortable exhalation.
That's great. What I really love is that Gail Wetzler, who goes into the pressure system, breath as a pressure system, and you just said the exact same things. And definitely something that I really wanted to get across on this podcast is that at rest, there's a natural recoil on the exhale and the inhale. There is a recoil. That unconscious aspect of our breathing is recoil. We're not actively having to try to do anything. Our abdominal muscles aren't coming into play yet during this unconscious breathing.
That's right.
Or our accessory breathing musculature in our inhalation isn't coming in to breathe yet in our quiet breathing. There is that elasticity, that natural recoil. And I'm so happy that both of you talked about that.
Great.
So then, do you want to talk about forced inhalation at all and exhalation?
Yeah. So, when we're more active and we have to get in more oxygen to the system for higher activity, we start to use more muscles within the accessory muscles of the chest, of the shoulders, of the neck, and those start to contract to really expand our thorax to a greater extent, to pull in a higher volume of air more quickly. And then, if we're talking about singing or speaking, where we're having to pressurize the exhalation over a long period of time, we're actually starting to utilize the muscles of the abdomen to help us pressurize, to assist in that elastic recoil of the respiratory system at the very end of our breath. So I can talk a little bit more about that when we're discussing volumes.
Yeah. So again, same thing. I love this. The importance that our accessory breathing musculature, it's not just in our neck, it's all around. Anything that's attaching to our rib cage to assist with inhalation or exhalation is an accessory breathing muscle. Though the primary ones are in the neck, sternocleidomastoid, scalenes, and pec minor, there's a lot of other musculature that's coming into play that's assisting with a forced inspiration or forced expiration. And it's way more involved in our chest wall and in our abdomen. So I'm bringing that up because we get so stuck and isolated around the area of the larynx. And it's so important to remember that there's all of this other musculature when you're singing that is coming into play.
That's right. Absolutely. Yeah, and I see that play out in dysfunction where either people who sit for long periods of time, or they have scoliosis or kyphosis that they haven't addressed, and those muscles become elongated and weak. That's when I actually start seeing more activation of the laryngeal muscles to try and compensate for those bigger stabilizers not functioning well.
Absolutely. And that's a huge part of what's happening now in our society with everyone texting and sitting at computers and having their head come forward and their chest start to concave, and the postures that people are finding, because then that musculature that's elongating and becoming inhibited is creating hyperfunction in other musculature.
Yeah. Yeah, it's like repetitive stress injury, right? It's people
Yeah.
looking at their phones all day long. A lot of times I'm working with stretching out the SCM, strap
Yeah.
muscles in the front of the throat.
So, can we talk a little about the basics of breathing when it comes to tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume?
Yep. So the average person has the capacity to move quite a bit of air. It's about 3 liters to almost 5 liters of air, and that depends on sex and age and overall size, overall fitness level. And so we call this full volume of air, how much you can fully inhale and exhale, vital capacity. So when you go to, if you've ever had the experience of going to a pulmonologist and getting a test where he uses or she uses a spirometry or device where you can measure the speed and the volume of breath, you have had the experience of getting your vital capacity. So that's when they say, I want you to take the biggest breath of your day and just exhale as much as you possibly can through this little tube. So when we're breathing at rest, we inhale and exhale at around 30 to around 40% of that vital capacity. So the very, very last ounce of breath being 0%, and the very, very top of our breath, we can't possibly inhale anymore, being 100%. So when we're just hanging out and relaxed and we're breathing, we tend to inhale and exhale around 30 to 40% of that vital capacity. And so we have the ability, and we call that, by the way, tidal volume. So we have the ability to inhale more above that comfortable inhalation. So that's called the inspiratory reserve volume. And we also have expiratory reserve volume, and that's the amount of air that you can exhale after a comfortable exhalation. But there's still going to be air inside your lungs because the lungs are attached to the inner portion of the thorax, and that's the residual volume, right? So that's the air that's left in the lungs that's always going to be there. And
Mhm.
so when we are just talking, we change how much we're inhaling and where we are in our vital capacity. So we inhale to about 55 or 60% of the vital capacity. And then when we sing, we'll inhale to about 75 to 80% of the vital capacity. Now, compared to quiet breathing, we also control our respiration differently when we speak and sing. So for quiet breathing, tidal breathing, we spend about the same time inhaling and exhaling, right? So it's about a 50-50 ratio. But when we're speaking or singing, we inhale really quickly, and then we spend a long period of time supporting the vibrations of the voice in an exhale. And so we spend 10% of the time inhaling and then 90% of our breath cycle exhaling. So that's always really interesting. It's funny because I don't think there's been a lot done looking at the kinematics of breath when things go wrong in singers. Is it that their muscles start to become miscoordinated so they're beginning their breath at different volumes every time, and then maybe they're ending their breath at different volumes? So typically, as a singer, you start at 75 to 80%, and then you stop just before the resting expiratory level, right? So that allows you to control for those extremes of elastic recoil, right? So you kind of stabilize the breath in that way. But some singers, they'll sing to the very, very edges of their breath, and then they're having to
Mm.
deal with all of the intensity of the elastic recoil of the thorax.
Mm. That is so fascinating to me, particularly around dysfunction and particularly around dysfunctions that can arise after an emotional trauma
Mhm.
that might affect our breath,
That's right.
and how affecting our breath will then affect the function of the larynx.
That's right. And that trauma can be both emotional and physical,
Hmm.
where they say, I used to work with Dr. Robert Sadeloff in Philadelphia, and he used to say, well, even stubbing your toe can change the way you breathe, in that low kind of produced sound. And it's true. I mean, he was a brilliant man, and he was absolutely right. I think even some of those minor adjustments that we don't necessarily think about can disrupt that even consistent, stable breath pattern that can then, of course, disrupt the fine tuning of the laryngeal muscles as we sing.
Right. So, in the discussion of dysfunction, let's move on to some rehabilitation.
Mhm.
So, what are three common things that you might see in your patients that would lead you to work on their breathing patterns or their breathing habits?
Mhm. Yeah. So the cohort of patients that I see with airway issues where I'm focusing on respiration are either people who are having breathing problems in the context of their voice disorder. Since voice problems, I'm not sure we even think about that constant conversation that the voice is having with the breath. But voice problems can change the way a patient is breathing and speaking, just in the same way that changing the way we breathe can have an effect on the voice. So I'm seeing,
Mhm.
people who have voice disorders and therefore also change their breathing, or I'm seeing patients who just have airway dysfunction where the respiratory muscles become miscoordinated, and that leads to a lot of tension in the wrong places. And then part of that is airway dysfunction that can be caused specifically by the larynx. So, I mean, I think it's funny to think about the larynx as anything other than a sound generator, but the primary function of the larynx is to regulate our airflow and to protect our airway. And so, if there are changes where the larynx becomes hyperreactive, either because of an external trigger or maybe an internal change, it can disrupt normal breathing. And so, that's when I need to help the patient kind of redesign how to work with the larynx and restore the larynx to its natural patterns. So, in terms of breath patterns, I think one of the most common breathing patterns that I see, and you referenced this before, is breath holding. It's just
Mhm.
such a visceral response. So this
Right.
can happen either with physical pain or discomfort, either in their respiratory system or maybe in their throats, right, where the patient's trying to protect and conserve. So these are cases where I might see a more guarded posture or a rigidity of movement in the chest and the shoulders. Sometimes I often will see it in the jaw and the tongue, that
Mhm.
radiates all the way up to those regions. So the what I had just described, the breath holding and all those series of symptoms can also be quite common when people are experiencing a significant amount of stress. That stressful overwhelm, which we sometimes call stresspiration. Have you heard of that?
No, I love
Stress.
that.
So there's the effects of stress on breathing. And in those cases, if it's stresspiration, I can also see this predominance of shallow, chest focused breathing. So then the pendulum can swing in the complete opposite direction, where I start to see where I might see a patient who pushes an excessive amount of breath
Mhm.
through their voice. I see this a lot with vocal super users. Our postdoc, Adriana Schembel, a super brilliant woman who does a lot of research here with Aaron Johnson. She calls it voice leets. And these are people who are using their voice for upwards of 10 hours a day. So I saw a patient yesterday. She's in sales. She talks, no joke, nonstop for over 14 hours a day.
Wow.
I had a hard time wrapping my mind around what she must feel like at the end of the day. But so that's a situation where the vocal folds are so fatigued and she is just completely out of any sort of vocal energy that she keeps going just by the sheer force of dumping breath through
Mm.
her throat. Right. So I asked her, what she feels like at the end of the day. And she said, my stomach is sore
Mm.
after a day of talking, right? Because she's pushing all of that air. And the funny thing is that that's an appropriate movement, but it's so overused that then it becomes inappropriate. It moves into the land of dysfunction. I can also sometimes with singers, I see breath dumping, right? If there's these long periods of heavy singing, or singing in a way that feels uncomfortable or out of their range, so that's where I'll start to see excessive amounts of pressurized breath flow and register transitions, where the larynx is just inherently more unstable. And then also, of course, if they have a lesion, I'll see it in their upper singing range. So we've got breath holders, the breath dumpers, and then there's the muscle misusers, right? And oftentimes they overlap. So I don't see a patient who's just categorically in one area versus another. Many times it's there's a fluidity to some
Mhm.
that dysfunction, and one can cause the other. So the muscle misusers is in reference to the muscles of respiration just getting out of coordination. So that can be from an imbalance because of poor posture, or maybe an injury that causes the patient to wrap their body around that injury in a way that's uncomfortable. The patient can sometimes have a pulmonary condition or an airway disease that reduces their ability to breathe comfortably. So they form this workaround to compensate for that. And that might look, again, like shallow breathing, or for asthmatics and for people with COPD. I see a lot of breath stacking
Mhm.
where they don't return to their resting expiratory level. So they'll inhale and exhale a little bit, but not completely because of the airway restriction underneath their vocal folds. And then they'll just take the next breath on top of the breath that they've taken before. And that is a very common response with patients who have COPD or asthma or emphysema. Lastly, and this is, I think, more specific to what I do as a speech pathologist, is I also see patients who have breathing problems that are triggered by hyperreactivity of the larynx or the airway. So you might see this in a chronic cough or an excessive throat clearing. We can also see this in a condition that we call paradoxic vocal fold motion, where the vocal folds, which are intended to open when we inhale and then maybe slightly close when we exhale, start to move in opposition to this pattern. And so then they start to close when we inhale. And that's a very scary sensation because patients feel like they have an inability to breathe.
Mhm.
So that kind of comprises the majority of what I'll see. Yeah.
That was really wonderful information. I'm not going to lie, as someone who has had a major thoracic surgery, as you said, breath holding, as you said, breath dumping, muscle misuse, I was like, check, check, check. And then you mentioned that, it doesn't have to be one or the other. They can certainly all happen together, which I have absolutely experienced and have had to work. I still work very hard through it.
Right. And what I see with my patients is the frustration levels that build around that dysfunction can be tough to break down, right? Because then you lose that implicit just body knowing, right? When we were talking about the woman that you had interviewed who was discussing the elasticity, the elastic recoil effects, and those natural forces that are within the body, we stop trusting them when we get into dysfunction, right?
Mhm.
And we not only stop trusting them, but then we stop knowing them
Mm.
in that very human, nonverbal way of just relaxing and letting the body do what it does best. There's two points in the brain that control breathing. And so we have this voluntary part of the breath that's controlled by the motor cortex, right? And that's where we can choose to take a big breath before yelling or before prolonged sung tone, or maybe we're choosing to breathe and control our breath in yoga, right? Pranayama breathing is all about the control of breathing in different environments. But then when we sleep, how do we get through the night? We breathe with our brainstem
Mhm.
and the medulla and pons area. So that's automated. There's almost always a little bit of overlap during our day when we're not thinking about breathing, where the two are constantly in this push and pull. And so if you've gotten into a state where there's dysfunction and you're starting to push more and more and starting to do more and more with a system that really does quite well when we're not over manipulating,
Mhm.
that can send us down a very slippery path.
Right. And with any kind of physical trauma to that area, how it affects, that's why I'm going to get into an episode with Zena Marcel on the psychology of breath. Because
Fantastic.
as I started performing after my thoracic surgery, every music director said, Christine, you need to breathe.
Mm-hmm.
And them saying that to me immediately initiated a sympathetic response within me.
Right.
I was very much ignited or triggered by those comments, and I heard it all the time. So I had this emotional connection
Mm-hmm.
that would trigger my sympathetic nervous system, my fight or flight, when someone
Right.
said, "You are not breathing."
Right. And then it becomes part of what you think is your identity as a performer,
Mm-hmm.
which can really be difficult to work through when suddenly you've invited this thought of, I breathe this way. When I sing, this is how I breathe, because other people have influenced your thinking in that way. Yeah, it can really be problematic.
Tricky. It's very,
Mhm.
very tricky.
Mhm.
So, are there special techniques to assist someone who has emotional holding or an emotional connection with their breathing?
Yeah. Well, so you had mentioned this trigger response, right? And it's actually very primitive. When we respond like that, it feels emotional, but there's also quite a reflexive aspect to it that we don't even realize is there.
Mm,
So part of my therapy when I'm working with someone who's had some of that emotional traumatic response that's invested itself into their respiratory patterns is educating them and maybe putting some labels to it or verbalizing it, that mind body connection, and then giving my patient permission to walk through that door of talking about emotion with breathing, because sometimes we don't even recognize that there might be a connection there and how their emotions might be influencing their breathing. And also just moving towards just some of the exercises that I use. I'll work with mindfulness,
mm,
and creating a safe space can be the foundation of establishing good mindful practice when we're trying to zero in to something as organic and tied to our emotions as breath. Sometimes I'll use a series of exercises that helps the patient experience breathing in different ways that maybe serves as a physical release, and sometimes that physical release can then help them maybe free up an emotional release.
mhm,
So so I might have a patient purposefully tighten and then relax different accessory muscles or different muscles within the respiratory system. So the abdominal wall, the shoulders, the neck region, the jaw, the tongue, and then breathe in those environments. And then I might work with breath pacing where I'm counting as they're inhaling and exhaling, just to help them maybe experience a different ratio.
mm,
So if they're breath stackers, it could be that their inhale is actually longer than their exhale. And so they're not giving themselves that opportunity to fully release. And so then I'll put them in a position where they have to get back down to their resting expiratory level. And lastly, I really like working with prolonging breath pauses. So, breath pausing naturally occurs at the end of a comfortable exhale and just before you start to inhale again. So, I find that just letting the body hang out there for a little bit in stillness, you're just finding that equilibrium state and just being with it a little bit can be like a reset button for their breathing, especially if they're using so many different kind of forces and activity within the muscles that are not necessarily inherent to easy breathing. I can't stress enough how important it is when I'm doing this to establish a safe space. So, spending time creating a connection where a patient feels heard, I think that's really important. I feel like my patients are more apt to move through the exercises, be more open to them if they feel like I'm an advocate, like they feel like I'm there for them. And then also establishing a situation or environment where if the patient wants to release some tears, they feel open to doing that. I'm giving them permission to reconnect with the emotional response once the physical response is explored or maybe opened up.
Mm. I'm really glad that you mentioned breath pauses. I've been reading a lot on the topic of breath, and that continues to come up in the books that I'm reading. And for me, and possibly for some others, some of the listeners, as I was reading it, I was thinking, but I'm a breath holder. Can you talk a little bit about how breath pausing is different than breath holding?
Yes, that's a great question. So there's a difference between allowing the body to experience the equilibrium of just the muscles being at rest versus a pause where it's governed by a tightening of either the larynx or the chest or the abdomen, where
Mm.
you're literally containing breath in a forceful manner. So, what I might do prior to exploring the breath pauses is working with an awareness of whether the body is in a place where there might be a persistence of abdominal holding, a persistence of throat compression, or the shoulders being raised, or the chest being tight. Sometimes the only way I can get at this is lying the patient down on a table where gravity can help them feel that sense of release and
Mhm.
that sense of softening of the muscles. And then once that occurs, I can start to get them to feel that there's this natural place of pause where the body really isn't needing to exhale or needing to inhale.
Fantastic. That is so great. Thank you so much for going into that.
Right. Yeah. I'm glad that you asked that. I think that many times as therapists, we get hyper focused on doing. And
Mm.
in that case, it's actually getting the patient not to do.
Hmm.
And I find it really, really helpful for myself, to get back that mindset of just being in quietude, both with my mind and with my breath.
Mm. It's so important
Mhm.
and very hard to do.
Mhm. Oh, yeah.
What would you say are the benefits of exercising the muscles and the structures that are involved with breathing or the breathing mechanism?
Yeah, so this is a really interesting question because there are two ways to answer this, right? There's the merit of just whole body exercise. So you can inform the use of muscles that are supposed to be bigger players in grounding breath, like those postural muscles. And that can also take weight off of maybe some of the inappropriate accessory muscles that we've recruited to help in that dysfunction. But I think we also need to be sure that we're not putting more layers of effort into an already malfunctioning system.
Hmm.
So, whenever I'm working with that idea of exercises and building a sense of strength and groundedness within the structures of breathing, I tend to try and zero in on areas of excessive strain first and then work up building respiratory drive. So that actually leads me into talking about some of these devices that are now on the market that are specific to training or building strength within muscles that control our inspiration or muscles that control our expiration. So there are quite a number. I actually just looked on Amazon again to appreciate these breath training devices. And there are probably triple or even quadruple the amount that there were, 5 or 10 years ago.
Wow.
And essentially, what these devices do is that they provide resistance to the inhale and exhale. So, with athletes, they're often trying to maximize that efficiency of taking in breath, right? Because that's going to oxygenate the muscles and improve the function of the power of their muscles. And so they get better performance by training the external intercostals and the chest and the neck muscles to be stronger and maybe more reactive. I should actually say that you don't train the diaphragm.
Mm.
In Steinhardt, when I'm teaching my speech pathologists, or we also have a program through NYU to train vocal pedagogy students in a certification program we call vocology. So we talk a lot about the diaphragm, right? Because everyone wants to know more about it, and it's essentially an autonomic muscle. We don't decide to contract the diaphragm, and so it's hard to specifically isolate the diaphragm in these types of strength training exercises. So I just wanted to put that out there. Diaphragm can't like hypertrophy. It can't get stronger in that way. But maybe it can get more coordinated, right? With
Mhm.
as the extrinsic muscles get stronger. And then as of late, we're also seeing in speech pathology, we're seeing this push to looking at the effects of training expiratory muscles for the purpose of stabilizing the respiratory system for singers, but then also for the protective aspects of the larynx, for coughing, for improving the body's ability to clear the airway from anything that might be a threat. And that's done with this one-way pressurized device. It's called the Expiratory Muscle Strength Trainer, EMST. And that can be set to release at a particular threshold. And then you train using principles of exercise physiology and strength training. So there are certain repetitions that you're going through. There are certain periods of rest that you're going through. And the woman who designed this device that's called the EMST is a researcher, and she's also a speech pathologist, Christine Sapienza. And she's really done the lion's share of work looking at this type of training for respiratory strength. And what she's found is, there's a series of benefits where we can see a strengthening of cough. Most obviously, we're going to see an improvement of expiratory drive, which can affect vocal stamina for singers. She took a look at these voice leads in Orlando at Disney, where they'll do 4 shows back to back and dance and sing for a total of about 6 to 8 hours. And she
Mhm.
saw that they were able to make it through much easier after about 4 to 6 weeks of training with this device.
Mhm. How do you go about training someone with EMST?
Mhm.
How do you assure that they're not hyperfunctioning?
Right. I know, because sometimes that pressurized valve can be too much for them. For people who are quite compromised, right? If there's a neurodegenerative disease where their muscles are significantly weakened, I might not start them with that. I may
Mhm.
actually just begin with something very gentle, like blowing bubbles through a straw in a cup of water,
Mhm.
where the water serves as that resistive property. I don't use EMST a lot. I'll use it if I think that there's enough of a dysfunction and they're a good candidate for this type of training program. But for the person who's maybe more mild to moderate in their breathing dysfunction, I'll go low tech.
Mm. Right. So, before we move on to my signature questions, Shirley, in regards to sleep apnea, I know you don't treat sleep apnea, but first I'd love for you to talk a little bit about what sleep apnea is. And then I know that you use the didgeridoo
Didgeridoo.
to work with sleep apnea. So can we talk a little bit about that?
Course. So first of all, sleep apnea is a sleep disorder where you experience apneic events while you're sleeping. And apneic events just means that you're periodically not breathing through the night. And there are 3 main types of sleep apnea. You can have obstructive sleep apnea, where the throat muscles collapse in on themselves while you're sleeping. This is above your vocal folds. And so that restricts your inhalation. There's also central sleep apnea, which is neurologic, and that's where your brain doesn't send the right signals to your muscles to ventilate. And then the third is called complex sleep apnea syndrome, and that's a combination of those two, which is the hardest to treat. And depending on the severity of the condition, the apneic events in sleep apnea can either occur just a couple of times per hour if it's mild, and it can move upwards in frequency to 25 to 30 times per hour.
Mm.
And you can imagine how that can disrupt the restfulness of sleep and lead to problems during the daytime. So if it's untreated for long periods of time, it can lead to cardiac problems, it can lead to stroke, it's been associated with diabetes, so it's quite serious.
Mhm.
And so to connect that with the didgeridoo, the reason why I know about it as a speech pathologist is because when I was at Brigham and Women's Hospital in Boston in the late aughts, like around 2007 to 2009, I was approached by a sleep specialist, a neurologist, who told me about this study that was published by a group in Brazil where they were able to show a slight improvement in mild to moderate sleep apnea symptoms by using this series of exercises for the throat and the tongue and the face. So he wanted me to explore with him why these exercises were helping. And then he wanted to try to get us to replicate that study with a set of exercises that would, in a sense, help to decrease the severity of sleep apnea. And one thing that he had educated me on was the biggest barrier here when we're talking about behavioral treatment is that when you sleep, you enter a semi paralytic state where the breathing is controlled exclusively by the brainstem, which is involuntary, right? So oftentimes what you do during the day may not transfer. I say may because I don't think it's been studied enough, but so far we haven't seen a transference effect on behavioral techniques that have been done with an awake patient to what's happening with sleep apnea while they're sleeping. So essentially my challenge was to find something that was impactful enough on the respiratory muscles and the brain that would lead to that transference effect and change in voluntary control of breathing. So I started to kind of hunt around and do some research on my own. And I found that just before the Brazil study was done, there was a smaller study that was done in the Netherlands looking at the benefits of playing didgeridoo. And they also found an improvement in symptoms for, I think it was 100 men with mild to moderate sleep apnea with the use of playing the didgeridoo. And they were playing, I think, once or twice a day, 5 days a week. And I just thought, wow, this is such a delightful concept to be able to take an instrument and improve our health with it. So I was like, I need to know what is it about the didgeridoo that may have influenced what they were doing with breathing. So I started lessons myself with a guy in Cambridge, and it was an unbelievable workout for just about every muscle involved in my respiratory system. So my lips were vibrating, my tongue was pumping back and forth, my palate was going up and down because I had learned to breathe in a circular manner, right? So you're kind of pocketing breath in your mouth and lowering your palate at the same time, and then doing that back and forth. And then also my throat muscles were getting that back pressure from this enormous didgeridoo that I was making sound in. And then of course I was breathing very actively. So we were going to move forward with the pilot study, but unfortunately I moved to New York and I had to drop it. But frankly, I'm still convinced that the uniqueness of that coordination of my breathing, and then the efforts of moving the mouth and the tongue at the same time, is probably what was key in helping these patients with mild to moderate sleep apnea. Now that is anecdotal. I'm going to put that out there, right? So that we don't have enough studies, robust studies that have been trialed to get behind what I'm saying. But in my experience, I found that to be quite powerful.
That is so fun. I hope you listeners enjoyed that because I just love that Shirley works with the didgeridoo.
And now it's a good party trick.
Yeah, right. I love it. So I expect everyone to go out and get a didgeridoo. Okay, let's move on to our signature questions.
Great.
What is some advice that you would like to give an aspiring young performer?
So I thought about this a lot, and I think the thing that I often find myself talking to with young performers is just getting to know your voice and know your body and feel comfortable in knowing it, both in its achievements, right, in what it can do, but then also appreciating it for its limitations. So I think recognizing the uniqueness of our gifts and our talents in a performer can play off that constant striving for pleasing other people and maybe possibly risking injury in the endeavor of constantly pushing to put your talents out there. So I think allowing yourself to rest in the knowing that as human beings, we have a lot to give, and there's an unbelievable beauty in sharing our voice with others. But then there's also limitations in that as well. And there's nothing wrong with those limitations.
What is your favorite quote?
Hmm. I had recently read a book by Atul Gawande. It's called Being Mortal. And it was such a powerful book about the interaction of the cycle of life and death with the current medical community. And so what he said was, we look for medicine to be an orderly field of knowledge and procedure, but it's not. It's an imperfect science, an enterprise of constantly changing knowledge, uncertain information, fallible individuals, and at the same time, lives on the line. There's a science in what we do, yes, but also habit, intuition, and sometimes plain old guessing. And I think that reminds me that even though I'm in the rehab a profession of helping people under the auspices of a medical umbrella, that I'm still human myself, and I need to first and foremost create a connection with my patients.
I just got chills from that quote, and it really, really definitely resonated with me in my manual therapy practice as well.
Me too.
So thank you.
Yeah,
That was
of
great.
course.
What are your favorite song lyrics?
So this was really tough. I can't put my finger on one, but I will say if I only had two albums to listen to until the end of time, it would be Bridge Over Troubled Water by Simon and Garfunkel
Mm,
and the White Album by the Beatles. Done.
great. Who influenced your work the most?
Initially, I leaned pretty heavily on my mentors within the field of speech pathology. So that's Patricia Doyle, Shirley Tennyson, who is my fellowship supervisor, Kitty Verdolini, who's a real beacon in my field, and then Michelle Horman, who was at Dr. Sadiloff's office, who kind of enabled me to bring my skills up a couple levels. But, currently my style and approach changes every couple of years based on what I'm reading or listening to. I really like going outside of the field, right? So, talking to people who are in behavioral change, like psychotherapy, talking to people in body work, such as yourself, talking to people who might be in business and studying group psychology. So, I'm almost always shape shifting my treatments to accommodate new things that I learn.
Yeah. What is something new about the voice that you learned this week?
So I have been taking a class on the craft of teaching. And one of the things that we're talking about is giving our students space to communicate. Just literal time, just dead space, which I'm really not that good at. I get concerned that I need to rush ahead and deliver more information and talk at the students. And so I'm actually learning in these past couple of weeks, I'm learning to bring that into my therapy room and also try and build out silence in my interaction with patients. And I'm finding that to be so valuable. You wouldn't believe what comes out of patients' mouths when you wait just another 5 seconds more to give them time to process and maybe give them the comfort to let go and find the words they're looking for.
Yeah. So providing the space to allow your patients to voice.
Mhm. Right,
Right.
right.
What is one item you could never live without?
I am working on a more minimalist lifestyle. I'm
Yeah.
really into the minimalist lifestyle and those philosophies. So honestly, I can't say there's anything in particular that I can't live without, but I love my morning cup of coffee.
You'd be surprised at how many people have said morning coffee. It's very popular. I thought you were going to say your didgeridoo. So,
Oh yeah, right.
what is one thing you have on your bucket list?
I am a big hiker and I'm starting to learn how to camp, like outback camping, where I'm hiking for 3 to 4 days at a time. And I really want to be able to do that in Yellowstone National Park. That is my
Yes.
list. So I'm preparing, getting all of the equipment and learning the strategies for safe outback camping because it's actually quite dangerous
Yeah, it
in some
is.
respects.
Ah, what is the most delightful word you can think of?
This is bizarre because the meaning of the word is not delightful, but I love the word kerfuffle.
Uh-huh.
You can't not smile when you say that word.
Yeah. Kerfuffle.
Kerfuffle.
What is your favorite book?
Now it's a Gawande's Being Mortal.
Yeah.
Absolutely, hands down. I read through it. I just have to read through it again because there's so many parts to it that as a medical practitioner, I feel like I can grow and learn from. Yeah, so that is my favorite book. Mhm.
Mm. What are you currently learning?
The Craft of Teaching. It
Mm.
is surprisingly different than what I had just intuitively thought teaching was about, which is just going up to the front of a classroom, parking yourself there behind a podium, and barking at the class for an hour and a half to 2 hours. And what I'm finding is that best practice is actually making yourself as a teacher inconsequential. What you're doing is you're crafting experiences for your students to then pick up and engage with the information that you're wanting them to learn.
Mm.
Mhm.
What do you wish you would have learned sooner?
Oh, radical acceptance.
Hmm.
I think both of myself and of the personalities that I share space with in this world.
Mm.
I think a lot of my issues and maybe my emotive responses have come from the resistance of what is,
Mm.
either with myself and what's happening in the moment or in response to someone else. And so I'm still learning that. I think that's going to be a lifelong endeavor and a lifelong lesson. But I'm starting to engage with that, and I wish that I had done that in my 20s. I think I,
Mm.
I would have had a lot less strife in my life. Hmm.
Uh, Shirley, this has been amazing. If the listeners want to get in touch with you, what's the best way to do that?
Sure. Thank you so much for having me here. It's always a delight to talk to you. You have this beautiful gift of being able to zone into the good stuff and really unpack those important ideas and things that people remember and people want to know. So thank you for taking the time. I know these podcasts take a lot of effort, and I appreciate you for doing that. So if listeners want to get in touch with me, the best way to do that is by email. So my email, it's my NYU email, GHERSS01 at nyu.edu.
Great. And I will have that in the show notes too. Listeners, this was with Shirley Gherson, an amazing speech-language pathologist, full of light and love. You cannot go into that office without feeling absolutely incredible when you come out. Shirley, thank you so much for taking the time to be with me and to talk about breath today.
I am most humbly thankful for you. Thank you.
Thank you all for listening. If you enjoyed this podcast, please share it with those you know. You can also subscribe, rate, and write a review. If you want to connect with me, you can now find me on Instagram under The Visceral Voice. You can find me on Facebook under my name or under Lifelight Massage, or you can check out my website at lifelightmassage.com. Please join me in 2 weeks for another wonderful conversation on The Visceral Voice.